Hello, Samar. Can you hear me okay?
Yeah,
Hello,
Okay, good.
hello.
Hello, welcome.
Is everything right?
See, I see there's an echo.
good morning, Mr. Jones.
Good morning. Yeah,
Just to problem with the
yeah,
voice.
yeah, a program is open, probably a YouTube somewhere. It could
Yeah,
be me. It could be me. Let me see here. Yeah, it could be me. You still get it? I think it was me.
Hello, John. Hello. Can you hear me?
Yeah, I'm getting off all my screens. You guys might do the same, other than the Zoom, of course.
Okay.
Yeah, somebody has an open screen on their computer. Yeah, check the computers, make sure all the programs are off, other than the Zoom. It's a rough looking crowd.
How are you, John?
Hello,
How are you?
good, how you doing?
We should start animate now.
We had 1,500 people watching from China yesterday.
That's very good, very nice.
Yeah, so there's more people than are here.
You mean 150 people? 1,050 people, 500 people. John? John, you hear me?
I'm sorry, what'd you say?
Do you hear me or no?
I don't understand you. I'm sorry. It's my hearing's not good.
You can hear me now or no?
Go ahead. What'd you say?
Can you hear me now?
Your voice is it's not good. The microphone is not good. You need to fix the microphone.
How about now?
Now, talk again. Do again. Talk again.
Do you hear me now?
It's not very good. I
Not
don't
clear.
know why. You can check it on a smartphone. Go to Neurosurgical TV and you'll see how it sounds. Do you know what I mean? Go to Neurosurgical TV and you'll see what everyone else sees.
Okay, we will try that. We will try to solve the problem now. يا سمير حلت المشكلة؟ John, how about now? Is it better?
It's still the same. How about someone else? Is someone else listening to that? Can you guys in the panel tell me how it sounds?
Hello,
Hello,
John.
someone in the panel, please help me.
Hello, John.
How does Ahmed sound to you? Other people in the panel, please help.
You hear the sound clear or no? Please.
I think it sounds okay now.
It's good.
I think so.
Yes,
So the panel won't help me. Thanks a lot, guys.
Our voice clear now? Can we start now, John?
Oh, you ready to start?
Yes, it should be started. We are already 5 minutes late.
Okay, tell me when you want to start.
Can you start recording?
Now we
I
have
can't understand you. Do you want to start now?
You will start now, and you can start recording, and I will introduce.
Okay.
Okay.
Okay, so you ready?
Yes, we are ready.
Okay, we have to get on the screen, off the screen there, because I want to introduce the face, not the PowerPoint. Okay, now let me get mine off.
Muhammad.
And watch this magic. I'm going to put magic on. I'm going to put a different screen on. So, okay, here we go. 10. Wait. 10. Let me make sure everything's okay. Okay, that's okay. Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning, good night from Miami Beach, home of Neurosurgical TV. We're broadcasting today. Oh, we'll get off the screen share here. Let's start again. Okay, let me take the screen share off. Now this is a personal program. Zoom is a personal program. And I don't like starting slide. Excuse me. I like starting with the face of the person that's presenting, not the PowerPoint. Well, I don't want to pick us to meet someone in the corner that has an icon. I want to see the whole face. Okay, so leave the person on, let them introduce themselves before they share the PowerPoint. Okay, here we go again. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good evening from Miami Beach. This is Dr. John Bennett. I'm introducing a fifth annual Yemeni Neurosurgery Hybrid Conference run by Ahmed Al-Jaradi, who put it all together. And I'm going to introduce him, who's going to basically run the program. Good day, Ahmed. It's all yours.
Good morning, John. How are you? And good morning, everyone, and welcome to day 2 of the 5th Yemeni Neurosurgical Conference. We will start our conference in the day 2 with Professor and Dr. Mohammed Al-Khashani. Dr. Mohammed Al-Khashani is a consultant neurosurgeon and head of department at Azal Hospital at Neurosurgery Department. Dr. Mohammed Al-Khashani will talk today about brain aneurysm surgery as a new field in Yemen. Dr. Mohammed, you can start, please.
Okay, we're all set.
Yes, we'll start now. Dr. Mohammed, are you ready?
Good morning, everybody. My lecture is about aneurysmal brain aneurysm surgery in Yemen. You know that this branch until last 4 years in Yemen, it was nearly closed totally because there was no facilities and nobody started at that time. Then some of our colleagues they started to do some cases. So I will speak about my own experience. The 8 cases I started here personally. All cases, okay. If you speak about the obstacles, there are much great obstacles. Some of them is the intraoperative angiography. You know, it is very important, and now it is internationally, it should be done in every aneurysm case, except small aneurysms. We have also the preoperative and peri-discharge angiography also difficult to do because of our financial position in our society. Also the 3D angiogram reconstruction. And some big aneurysms, you know, you need the 3D, you need the adenosine cardiac arrest to evacuate the aneurysm, which is not available also. And also you have the brain protection measures like barbiturate and hypothermia. All those are obstacles. I will speak with time with every case about some obstacles. I did all my cases in Azal Hospital, because we have their new microscope, operating microscope, and we have a complete microsurgical set. Okay, case number 1, old male patient, around 55 years old, presented with acute subarachnoid hemorrhage. The angiography was showing that he has ACOM aneurysm. This is a surgery I did. This is the first, the beginning of exploration. You have here the optic chiasm. Here you have the carotid artery, left side. After proceeding with dissection, this is the ACOM started to appear. Here you see that the rectus, the posterior part of the rectus gyrus is the main obstacle here, and you have to dissect it and remove it. Small part, according to your approach. If you have done frontozygomatic or extended terminal approach, then you can avoid this because you have a big open window. If not, you have to remove part of it. I think صدام في بروبلم ما بيقلبش الشريحه ما تقلبش الشريحه ما بتقلبش يا اخوان الشريحه ما بتقلبش انا رجعت ورا خلي بطريقتي يا صدام خلي بطريقته كنت شربت سهل قلب اوكي شغل مين يكون قلب
اضغط هكذا بعدين
Okay, after finishing the ipsilateral artery, now you have to start from the contralateral. You have to see what is the common carotid and proceed to ACA other side. I hope that photo is clear with you. Is it clear? You can see now the other carotid artery started to appear. And by proceeding in dissection, other ACA, another contralateral ACA will appear also. Here you can see. This is the optical carotid angle, sister. Now I'm waiting for the other ACA to appear. This is my hope now at this stage. You have to reserve all small branches here and there. Now I'm removing, as I said before, part of the rectus gyrus to expose the field through what's called sub-PL transection. Now you see that the contralateral E1 started to appear here. Because I know the dome of the aneurysm is adherent tightly, so I started to do temporal eclipse, contralateral. Now I'll do ipsilateral. Okay, now we will start to dissect. This is the dome of the aneurysm. This is the big aneurysm. Now I will start to do dissection here. طبعا لاحظوا اثناء الديسكشن لازم انك تحافظ على البرانشز هذه كلها. معك هنا تو تايبس اوف برانشز، معنا البرفريترز والريكرنت ارتريز. الريكرنت ارتريز sometimes اذا في ريدندنت او سمول او اتريتيك A1 بيكون الريكرنت ارتري كانه يول مس ماتش يعني بتوين ذم، ما تقدرش تميز اين الريكرنت وين ممكن تضربه حتى اذا مش منتبه. لاحظ الان I'm separating the dome of the aneurysm. Branch, for example, this branch also, you have to preserve all of them. Proceeding more with dissection. طبعا لو واحد استعجل الان ممكن يحط الكليب هنا in this place، لكن هتشوفوا بعد شوي انه بيظهر لك الكونترالاترال E1 ماسك فيها يعني، فانت ممكن تتغلقه بيضاوي اذا ما انتبهت يعني. لازم تعرف كل ما حول الانيوريزم، all branches, all where is the E2 ipsilateral, where is the E2 contralateral, then you will put the clip. Recurrent it will appear now. It will appear now. وطبعا احد المين بروبلمز في هذا الستيب يعني بيعمل لونج كورس ويخرج على البايفوركيشن ويلف احيانا حتى مع البروكسيمال بارت اوف ذا MCA. This is the dome you can see now. Okay. شوفوا الايتو فين ظهر الايتو يعني بكل بساطه كان ممكن تغلقه معها. هذا هذا ريكرنت دكتور رشيد، هذا واحد، هذا سيداو. هذا الريكرنت الاوريجين حقه. عشان التايم لانه بنحس الوقت يضرب. تقريبا الان مخلص الريليز للدوم. هذا الاي 2 ابسلاترال اي 1 اي 2. احنا الان في الايكوم هنا. هذا الايكوم نهايته هنا. هذا recurrent artery also. You have to preserve all branches. I applied the temporary cleanse because the dome mostly it will rupture يعني. So I applied until I make complete dissection of the dome. This is the contralateral. هذا الايكوم وهذا الاي 2 الكونترالاترال. الديسكشن تقريبا مخلص، شبه مخلص الان. الان حتى لو حصل بليدنج ما عاد يهمنيش لانه انا قد حررت النك. I identified all branches. انا ايش باقيه؟ ما يعني شيء لا يصدق يعني. لا التايم مناسب من حيث البدء ولا التايم. طيب احنا بدأنا كم؟ 8 وكم؟ اذا I need another time. اذا تشوفها لي وقت ثاني اقدم المحاضره. لا اليوم ما اعتبرش اني قدمت هذا الحين. ما اعتبرش اني قدمت المحاضره النهائيه. معي 5 حالات. اقل شيء نص ساعه اخذها وافيه يعني. ما اعتبرش اني قدمت محاضره ابدا.
نعتبر دكتور محمد الخيشاني بس احنا بلغنا دكتور المحاضره هي ربع ساعه. العفو منك. ثانك يو دكتور محمد.
Next lecture, Dr. Khalid Saleh, Senior Consultant of Neurology in Military Hospital, Assistant Professor at the Mar University in the Neurological Egypt. Can you start, Dr. Khalid? Start, Dr. Khalid.
Perfect.
Dr. Khalid, are you ready?
صباح الخير. هذا الجامعة. Let us start the case presentation. Neuromyelitis optica spectrum disorder. This is a female patient, 12-year-old female, admitted in Azal Hospital because of disturbance of conscious level. The patient was unwell 2 weeks preceding the admission. She had a headache and vomiting followed by weakness and dysphagia. She became unable to walk. She got urine retention and became confused. Then take him to the hospital. When I saw the patient, she was comatose on ventilator in the hospital, and the pupils were constricted with a sluggish reaction to light. There was bilateral edema by fundus exam. The limbs were flaccid, and the reflexes were diminished. The blunt responses were upgoing. The blood tests were normal. Anti-echoburin antibodies were negative. Antinuclear antibody and anti-double-stranded DNA were normal. CSF, there was only elevated protein. Now we'll see what are the findings on the brain MRI and the spinal MRI. Flare axial showing this lesion in the antennal capsule, and also in the right frontoparietal area, there were 2 small lesions. In the brainstem, there is a large lesion. This in the bones. Also, this is in the pontine lesion with the cerebral peduncle. This is another view. This is the sagittal view. Here we see the pontine lesion, and here in the medulla, there is also another lesion. Here there is an area called postrema region, which is the cause of vomiting. Diffusion, there is a slight faint restriction on the diffusion. On contrast, there is faint enhancement. What is the differential diagnosis of this lesion? Is it ischemic, compressive, inflammatory, or infectious? I asked for the spinal MRI. When I see this patient, I asked for the spinal MRI, and the diagnosis was settled after the spinal MRI. This is the spinal MRI. Here in the dorsal region, there is a large area of hyperintense lesions involving more than 3 segments of the spinal cord. Another view, here is the transverse myelitis. So there is transverse myelitis, brainstem lesion, cerebral lesion. The diagnosis is going with neuromyelitis optica spectrum disorder. Let us see how was the course of this patient. The patient was treated with IV. When I saw the patient, she was treated with IV acyclovir for presumed viral encephalitis. But after the MRI findings, I thought about the neuromyelitis spectrum disorder and start with her methylprednisolone for 5 days. Unfortunately, the response with methylprednisolone was poor. So I started soon with IVIG. After IVIG treatment, the patient improved dramatically. She opened eye after 2 days, became fully conscious 4 days after treatment, moving limbs after that, tracheostomy done 10 days after admission, and after that the ventilator was weaned. There was gradual and significant improvement in walking. The patient became walk completely free without any findings. I kept her on prednisolone as a chronic therapy. So now we will discuss what is the NMO STD. This is the control MRI done 6 months after the initial MRI. See the difference between the first. See the first. And this is the second. A marked and remarkable improvement in the lesions which was in the brainstem. Also, there is remarkable improvement in the inflammatory lesions which was present in the spinal cord. What is the NMO STD? We will answer these questions. What is it? Where is it? And how is it? NMOSD is an inflammatory CNS disorder, autoimmune. It is distinct, different completely from multiple sclerosis. It has a special antibodies called anti-aquaporin 4 antibodies. Where optic nerves, brainstem, cerebrum, cerebellum, spinal cord. How? It is a recurrent aggressive disease. It needs a chronic maintenance therapy. The history of the David disease is very long. البداية كان في عام 1894 when it discovered by this French neurologist, and it called it David disease. David disease at that time was only acute neuritis, optic neuritis, and acute myelitis. No other manifestations, only acute myelitis and optic neuritis. Brain MRI should be normal. So the symptomatology changes over the time, and we will see what are the changes until the recent time. في عام 1999 optic neuritis, acute myelitis, no other symptoms of spinal cord. The spinal cord lesion should be more than 3 segments in order to differentiate it from the multiple sclerosis. في عام 2006 أضافوا إن يكون في حاجة يسموها NMO IgG seropositivity. وفي عام 2007 أضافوا الأنتي إكوابورين antibodies. في عام 2015 the symptomatology of the neuromyelitis optica changed completely. They put a diagnostic criteria for this, and now we will see what are the diagnostic criteria. If the anti-aquaporin antibodies are positive, we should fulfill one of the core clinical manifestations, which are optic neuritis, acute myelitis, characteristic brain syndrome, dorsal medullary, acute brainstem syndrome, acute diencephalon, cerebral syndrome. Any one of these manifestations, in addition to positive aquaporin, NMOSD is diagnosed directly. If the anti-aquaporin antibodies are negative, we need 2 of these core clinical manifestations. مرة ثانية, with positive anti-aquaporin antibodies, only 1 core clinical manifestation or 1 core clinical criteria should be fulfilled in order to diagnose neuromyelitis optica spectrum disorder. And in case of negative anti-aquaporin antibodies, 2 core clinical criteria should be fulfilled. In our situation, the anti-aquaporin antibodies were negative, but we have acute brainstem syndrome, we have cerebral syndrome, we have acute myelitis, we have also optic neuritis. So the NMOSD diagnosis is straightforward. NMOSD is different from multiple sclerosis and has a specific locations. Why it has a specific locations and predilection for some regions in the brain? It likes the regions where there is aquaporin channels. For example, in these regions, احنا نسميها هذه regions peri-ependymal regions. It is not like MS lesions, which are perpendicular, ovoid lesions over the ventricles. No, it is in the peri-ependymal regions, and also may affect basal ganglia. And multiple sclerosis never affects basal ganglia. Large lesions may affect the corpus callosum. Optic neuritis, this is the optic nerve which is inflamed. Area postrema, area postrema, it is the cause of intractable vomiting. So the patient may come to the OPD or to the hospital complaining only of intractable vomiting. Brainstem, especially around the ventricle, fourth ventricle, the spinal cord. What is the difference between the spinal cord lesions, between the multiple sclerosis and between NMOSD? In multiple sclerosis, the lesions are small, less than 3 segments, but in NMOSD, it is large lesion. It is called longitudinal extensive transverse myelitis. So, in neuromyelitis optica spectrum disorder, the lesion in the spinal cord should be more or equal to 3 segments. I mean, it is extensive and longitudinal lesion. What are the clinical considerations in such cases? 90% are recurrent or relapsing, and 10% only monophasic. We have to exclude a systemic autoimmunity like systemic lupus and Sjogren's syndrome, myasthenia gravis. It is a progressive. Come back. It is a progressive disease. We have to exclude neoplasm, sarcoidosis, chronic infection like HIV, syphilis, and TB. Differential diagnosis, multiple sclerosis, differential diagnosis of extensive transverse myelitis, multiple sclerosis, MOG, Sjogren, neuropathy, sarcoidosis, post-infectious, named encephalomyelitis, dural AV fistula, anterior spinal artery infarct, vitamin B12 deficiency. What is the first line treatment in such case? It is methylprednisolone. And if there is poor response to methylprednisolone in large doses, the second line is plasma exchange. Unfortunately, plasma exchange is not available here. So we will start with the IV immunoglobulin. What is the chronic treatment for such patients? لاحظ, do not use natalizumab, interferon, and fingolimod الذي هو بيستخدم في المultiple sclerosis. We have to use azathioprine, rituximab, and the second line is mycophenolate and methotrexate. And the future treatment, which is approved by FDA, is eculizumab and inebilizumab, satralizumab. I kept my patient on oral prednisolone and she is doing well. Thank you very much.
Thank you, Dr. Khalid. Thank you very much, Dr. Khalid. Nice lecture, and thank you for التزامك بالوقت. يعني نشكرك يا دكتور خالد على هذا الشيء. Now we'll move to our next speaker. Dr. Khalid bin Madi. Please come on stage. Dr. Khalid bin Madi is Associate Professor of Neurosurgery and Spinal Surgery in Hadramaut and Technical Director at Al Burj Hospital at Mukalla. Dr. Khalid will talk today about calcified chronic subdural hematoma, mimic meningioma. Dr. Khalid, please, you can start.
Yeah.
I can't figure out what happened.
What? Go get in the Zoom.
I don't know what happened. I just went away.
Okay, Kurt, figure it out.
Well, I see you, but I got a shirt on.
Kurt, you're in a video chat with me. You're not in the conference. This is the video
I know.
chat. You have to go
Right.
into the Zoom link. Go to the Zoom link that I sent you. Here, let me get it.
Right.
Hold on. Let me get it, Kurt.
أغيرهم.
I want to do all that.
Assalamu alaikum. I'm sorry for waiting. My presentation today is calcified chronic subdural hematoma, mimic meningioma. The calcified chronic subdural hematoma
is very rare. The first case description is in 1884. The incidence classification of chronic subdural hematoma has been reported to be 0.3% to 2.7% of all chronic subdural hematomas. The optimal surgical procedure for this type of lesion recommended due to armored brain, which is insufficient expansion of it. The calcified chronic subdural hematoma is challenging diagnosis regarding to diagnosis and management. Case presentation: 27 years old male had gradual onset of right hemiparesis on one side from 1 month before admission, with history of evident trauma 15 years ago and history of right focal convulsion or epilepsy since 13 years ago. On admission, patient was fully conscious. The muscle power was grade 3 to 5 on right lower limb and 4 to 5 in right upper limb. CT brain and MR brain were done. All radiological reports reveal extradural lesion. Mainly calcified hematoma with differential diagnosis, atypical meningioma, bone tumors, as shown in figures. This brain CT scan, also this is MRI. The lesion may be extradural, but really it is subdural. Intraoperative finding under general anesthesia with supine position, left frontal scalp flap and left craniotomy were done. We found no extradural lesion. When we search, no extradural lesion. We are feeling lesion like hard mass under dura by finger palpated to dura. The dural flap created with meticulous dissection, total removal of hard mass which has gray to red outer surface and which whitish inner surface, which have multiple calcification, and imprinting over cortical surface of the brain. This also dura in no. This is dura also hanging, and this lesion, the outer surface of this lesion, like bone or mass, and this after removal. This inner surface of lesion, this is calcification or ossification. Histopathology relieve calcification in the reports. Hemostasis were done, used bipolar dithermy and Sergicil. Dural repair was done, reposition of the flap and closure wound in layers with suction drain. Post-operative day, patient improved and start to walk without support. Then day by day feeling he is better. The patient has been followed for 3 years. Anti-epileptic drugs stopped after 6 months post-surgical intervention. Conclusion: the theories of calcification of hematoma, how to occur and how to develop in chronic subdural hematoma till now is unclear. Some theories report calcification may be evolved slowly through process of hyalinization to calcification and eventually ossification. This process may take 6 months or many years to occur. These theories agree with time of calcification in our patients. He gives history of head trauma before 15 years. Calcified chronic subdural hematoma may manifested with scissors. Also, our patient gives history of convulsion, focal in type, many years in right side, and he treated from it by traditional method. Traditional method, this in our culture only. Cauterization of pectoralis muscle in left side. When he is not responsive for traditional method, he goes to medical specialist. Another problem in this point, gives anti-epileptic drugs, epileptic attack control by drugs for 10 years without brain imaging. This is another point for us. Maybe patient come with epilepsy without any imaging and treated for many years without any brain imaging. Sometimes confidence of diagnosis is need revision. One right side weakness was a bear, he make brain imaging. Traditional cauterization and late brain imaging, we disagree with them. And other papers also not agrees. Other papers which recorded mental retardation and brain atrophy as effect of chronic calcified chronic subdural hematoma, but in children. This is cauterization. Another point, dura may be adherent or tightly adherent to calcified hematoma and cortex. The dissection from brain may cause contusion or bleeding. The removal of this lesion has not been necessarily beneficial. If adherent to cortical blood vessels or central area in cortex. The surgical intervention is for progressively enlarged calcified chronic subdural hematoma. The last point, we report this case considered as rare cranial lesion with neurological deficit, which may mimic tumor. After revision of literature in recent years and our experience for this case reported, we recommended surgical treatment resulting in good surgical improvements.
Thank you very much, Dr. Khalid.
Thank you very much.
Thank you very much. It is good case and very rare case. Thank you. Next, we will move now to our next speaker. Next, we have Professor Michel Bobonowski. Dr. Michel. Dr. Bobonowski, are you there?
Yes, are you listening? Can you hear me? Hello, can you hear me?
Please unmute yourself, Professor.
Yes, hello, how are you? Okay, let me see. I would.
Professor, we cannot hear you.
Desktop, iPhone. I'm trying to open my slides.
Professor Michel Bobonowski is a full professor in the Department of Surgery at Montreal University and senior consultant neurosurgeon and the head of department and skull base and cerebrovascular unit at Cham Hospital, Montreal, Canada. Professor will talk today about supracerebellar transtentorial approach for vascular lesions.
Can you see my slides?
We cannot hear you, Professor.
Can you hear me?
The sound is not clear.
Can you hear me? Hmm. Can you hear me? Do you hear me?
Professor,
Can you hear me? Pourquoi ça marche pas ça? Hello?
John, John,
Can you hear
can you hear John?
You hear me? Yes. Yes?
Yes, perfect,
Is it
perfect.
problem from us or
Okay. Can you see my slides?
Let's see. No, like not yet.
Can
Not
you
yet.
see my slides?
No, I cannot.
Okay.
Can you click to share the screen? It says
please
share
share-
screen.
2 minutes? We have some problem with sound. We cannot hear anything. So
I'm clicking on share my
10
screen.
minutes until we solve it.
Participants raise hand, chat. Share right there, okay.
Can you see my slides now?
Screen.
No. Are you clicking the share screen button? Share screen.
I've done that twice, at least twice.
Oh, okay. What happens when you click that?
Let me see again.
On Zoom, start
It's
broadcast.
it's written here, basic advanced slides, desktop, whiteboard.
Okay, look for your PowerPoint. You're basically
I don't see it. I don't see it on my power. I don't see my PowerPoint on that.
okay.
Shit. Is it
Can you
maybe the
search? Can you
desk?
search? No,
Is
no,
it
it's on your. It's on. You got to search for it
Yes.
on your desktop. You're at a desktop, right? You got to search for
Yes.
your PowerPoint. Click. Well, I tell you what. Send your PowerPoint to me.
My power.
Can you send the PowerPoint to me? I'll give you my
Yes.
I'll give you my email address. Okay.
Yes, of course.
Okay, Michael.
I'm sorry about that, but
No, it's no problem. Everyone learns this once.
no, but we use Zoom all the time. I don't know why it doesn't work.
Yeah, I
now.
don't know why either.
Yeah.
On 2 feet, on your feet, and I can see your PowerPoint.
Yeah, I'm gonna give you this email address.
Gives me an option to share. But what would you share, Mike?
Okay, do you see my email address?
No, I don't.
It's in the chat. It's in the Zoom chat.
Okay. Okay. I will try
You
to.
know, okay.
Welcome invite. Oh, that's not what we want. In the Zoom chat. Okay. This is Zoom.
Okay. Is it gb@neurosurgical?
Yes, neurosurgical.tv. That's my. So can you email me your PowerPoint? Just
Yes,
send
I
it
will
as send it as an attachment, okay?
Again, just to make sure, it jb@neurosurgical.tv. Is that correct?
Correct.
Okay. It will take only a few seconds. Again, I'm sorry about this.
Okay. I can share your PowerPoint if you send it to me.
Yeah.
Zoom, could you check me off Zoom?
Message.
Everyone starts Zoom and everyone has to learn it eventually.
To join a meeting is.
Yeah. Again, as I told you, we use this all the time.
Register and join.
Well, every operating room you go to in the world is not the same.
Back in.
Some are different.
Been invited as a panelist for Yemeni Neurosurgery conference.
Okay, so
Invited.
Go ahead.
Been
okay,
invited
okay, I
as a
sent it.
panelist for the
It's
Yemeni
done, okay?
Neurosurgery conference.
Okay, let me check. Hold on, Ahmed. We got it. We're rolling. I'll be able to share the PowerPoint.
By the way, my presentation is not very long, so you won't. I don't think you will be too late because of me.
Okay. No, that's okay. We can always. I don't see it.
It's sent.
Oh, okay, no, I don't,
Did you receive it?
no, I didn't get it, no. Let me check the junk folder. No, it's not there. Okay, how can I communicate with you? Because we can continue the conference and I could tutor you. I could
Yeah.
teach you.
I have Team, I have Zoom, I have everything.
What's that, John?
Yeah, okay. Well, now what happens? Do you have the Zoom screen in front of you? When you click on that share the
You
screen?
know what happened is when I
I don't
tried
have the
to
Zoom anymore, it's gone.
when
I've got where
I
it says you've been invited as a panelist.
Okay, oh, Michael, we're gonna go on to the next speaker, okay? And I'll send me your email. Well, I don't have your email. Can you put your email in the panel, please? And you and I will communicate on how to do it. Meanwhile, we'll
Okay, I'm
continue
sending-
we'll continue the conference.
I'm sending it by chat right now, okay?
Okay,
Professor Michel,
yeah, and you can go on and I'll try to teach Michelle. Hold on, wait till I get his email address. I don't have his email address yet. As soon as I get that, okay. Okay, Mike, Michelle,
Did you receive it?
you and I will try to work it out, okay? Go ahead, go on, Ahmed, go ahead, go ahead. Now, is that yours, Michelle, that screen?
I see a screen broadcast.
Is that yours? Is that yours?
So what do I do with that?
No, is that yours? Okay, okay, Michael, excuse me, Ahmed, you go on, Michael, go on, Ahmed, go on with the conference.
you can hear me now, John, or not?
Go on with the conference.
We will go on with our next speaker.
Do you see my
Yes, okay, Michelle, don't talk.
Okay. So now we'll start with our next speaker until Professor Pogorowski solve the problem. Now we have Dr. Ammar Ali Al-Mikhlafi. Dr. Ammar. Dr. Ammar will talk today about causes of incomplete rejection of pituitary adenoma. After that, we will be with Professor Pogorowski again, inshallah. Dr. Ammar, are you ready? When do you receive the lecture of Professor Pogorowski? محاضرين محليين، يا ليت الجميع يجهز محاضرته. هذه محاضرة موجودة الآن، يطلع لها عند الاي تي، يدخلها في الكمبيوتر عشان ما يحصلش أي تأخير زي ما بيحصل الآن.
I don't know what he's doing. What, I'm saying, I'm not gonna talk to these. Right. I don't know what he's doing. Still online, yeah, I can still see him.
دكتور عمار، هل جاهزة ولا نبدأ مع محاضرة آخر؟
So I'm still connected. Plus I have the Zoom.
ما تأخر دكتور عمار، ممكن نبدأ مع المحاضرة التالية. جاهزين يا شباب؟ سمير جاهز؟ ابدأ اعمل سكرين شير.
No one can hear my audio.
Sorry for the delay. Now we'll have Dr. Ammar. He will start. Dr. Ammar, you have 15 minutes. Please. التزم بالوقت إن شاء الله.
Please, please. السلام عليكم. We will talk today the causes of incomplete dissection of the pituitary adenoma after endoscopic endonasal transphenoid approach. This is very important study we did in Cairo University to know the cases to identify the causes of incomplete dissection to improve the outcome to the patient. The causes is the bony work, the early descending of the diaphragm ocelli, the cavernous sinus invasion, the surgery experience, and the size of the tumor. The pituitary adenoma is the third most common intracranial neoplasm. There is different classification to the pituitary adenoma. The most of them, according to the size, microadenoma less than 1 centimeter, macroadenoma more than 1 centimeter, giant adenoma reaches 4 centimeter. 90% of the pituitary adenoma is microadenoma. Recurrent pituitary adenoma is defined as the reoccur of the tumor after removal totally.
Watching the comments, it's just
Or
showing.
regrowth of the incomplete size of the tumor. Both of them is under category of recurrence of the pituitary adenoma. The symptoms is according to the mass effect to the around the structure like optic apparatus or the hypothalamus, or to the hormone, increase hormonal production like growth hormone or Cushing, or impaired normal gland functional, which is more common with the microadenoma. Diagnosis is based on the clinical examination and the chronology testing, imaging, of course, and visual assessment. Management is surgical and medical, and we will focus about the surgical management. The general indication for the pituitary adenoma is a progressive visual loss or mass-related reduction of the size as adjuvant to the pharmacology, resistant to the pharmacology, pituitary apoplexy, a contraindication, inaccessible subacterial extension, especially the lateral extension, fibrous pituitary adenoma, active sinus infection, pituitary adenoma with adjacent aneurysm, or casing carotid. The transphenoid approach can be used effectively 95% for the resection of the pituitary adenoma. The rest, we can do this type of surgery by microscopic or endoscopic. The more advantage of endoscopic more than microscopic is the illumination and get wider view. In baby picture is with microscopic is narrow corridor we can get with microscopic. When you see this picture, when you see through the small hole by microscope, we can see this view. But when you introduce the sheath of the endoscope behind this edge of the small hole, you can get this view. The factor we found in our study is body exposure, early descending of the recurrent layer, cavernous sinus invasion, the size of the tumor, the surgical experience, the stages of this surgery is in initial stage,
We used to do this type of surgery with ENT consultation. The later stage, with the ENT consultant, we can avoid the post-operative complaining of the headache or crustation. Sphenoid stage, you have to notice before the surgery the type of the sphenoid is conical type or cylinder type or pericylinder type, the cylinder fluid opening. When you do this stage correctly, we will save optimal section at the end. The bone exposure is very important step in surgery, is the gate. The wider bone opening that allows more visualization, illumination, and very movement surgical instrument, which help to obtain maximum section. It's very important to do wider opening bone, to more visualization and the free movement of the instrument. This is the conical type, is about the minimization. The first one, second type is the cylinder type. The minimization is enrich the anterior wall of the floor of the cylinder, and the cylinder type is interior and beyond the floor of the cylinder. The base structure is called onodicell, which is the posterior part of the ethmoid cell is related to the sphenoid sinus. You have to note. In the sagittal plane, there is called onodicell. You have to note it before the surgery. If you go in mistakenly, it will lead you the skill base and get safe or the better structure like the optic nerve or anterior optic nerve. You have to note the safety before the surgery. We have to remove all the safety to expose the floor of the cylinder. This safety is go to the carotid. If you don't notice before, it will be injury to the carotid artery. This is the view. Optic nerve is carotid artery. This the OCR, medial OCR, lateral OCR, the planum, and the sphenoid. The floor of the cylinder.
You have 3 minutes or 4 minutes max.
This is the case. Growth hormone. This is the preoperative. This is the bone. Post-operatively, is the surgeon has left this bone without removal, and this is the post-operative. Residual hair behind the bone, not removed. The only descendant of the diaphragm cilia is maybe one layer or the diaphragm cilia itself. The diaphragm cilia may be descend unequal and there is pocket of tumor behind the invented tumor section. To avoid the early descending diaphragm is about the surgical technique. We have to open the cilia like smile face. Like a small face and remove inferiorly and the lateral to lateral, the second, the superior part. If the arachnoid layer is descend early, we can push by the small cotinoid and remove the hidden tumor. The cavernous sinus is during more destruction, some tumor is invading the wall because it's very thin and very challenges. There is classification. The surgical experience for the endoscopic is more difficult. Filling detail, it's a guess of 40 cases to reach the expert, and one detail is made 18 to 34 cases to be expert as surgical experience. The surgery experience plays a vital role where each step is dependent on the expert. The way in which the step affect the other makes the different results and outcome differ. The size of the tumor compared to the section of large and giant pituitary adenoma is difficult and often because the extent of the disease and invasion of the structure are not currently accessible surgically. The main factor is in the supracellular extension, the lateral extension is very difficult to remove from intestinal spheroidal, which makes it is very difficult. In conclusion, the surgical experience is the cornerstone for the surgical resection of the pituitary adenoma, which is treated by endoscopic transnasal transphenoid. The relation between the bone exposure and surgery experience is statistically significant. When wider opening of bone, more visualization, illumination, and free movement of the surgical instrument, which help to obtain maximum resection and vice versa. The experienced surgeon was able to wide opening, while the less experienced, they did limited bone exposure to avoid complication from the injury to carotid artery and optic apparatus. The relation between the resection of the tumor and the surgery experience was significantly. It is not to achieve good outcome in resection of the tumor. It is required wide exposure to allow free movement of the instrument and the surgeon experience, which is able to avoid any dissection of the diaphragm. To improve the abilities of the less experienced surgeon in this type of the surgery and the result of the outcome were much better, they need to pass through the learning curve using intraoperative neuronavigation, brain lab, and collaborate with the expert in consultation. Thank you.
Thank you very much, Dr. Ammar. Thank you. John, you can hear me, John? Okay. Professor Bobrovsky still has some issues. So until we don't solve the problem, we could move to our next speaker now. Okay, next speaker will be Dr. Abdul Karim Farhan. Dr. Abdul Karim, do you hear me? Dr. Abdul Karim. دكتور عبد الكريم موجود؟
أنا سامعك دكتور أحمد.
دكتور عبد الكريم also have
دكتور أحمد بسمعك، أنا سامعك.
So in meanwhile we'll move to our next speaker. Now we can start with Dr. Anas Ashumi. Dr. Anas, please come on stage. Dr. Anas Ashumi is a consultant pediatric endocrinologist and former pediatric endocrinologist at King Fahd Medical City in Riyadh, and former clinical assistant professor at Prince Noura bint Abdurrahman University in Riyadh. Dr. Anas will talk today about management of hormonal disturbance in pediatric patients post craniopharyngioma surgery. Dr. Anas, please start.
Thank you, Mr. Chairman, and thank you for organizing committee for inviting me to this diligent event in neurosurgery. I am a pediatric endocrinologist, and I will move a little bit from a surgical point of view to medical point of view. I will speak about endocrine problems that are mostly faced in cases of craniopharyngioma in pediatric population. Those patients usually develop endocrine complications, maybe at presentation, even before you touch the patient, or during surgery, or just after surgery, or after long-term complications after a while from surgical time. So my first advice is, before you touch the patient, you should diagnose and assess the patient hormonally for any possible endocrine disruption. As the craniopharyngioma, as you know, is a very big tumor that distracts the endocrine producing cells in the pituitary glands and hypothalamic area. So how much of time I have, Mr. Chairman?
15 minutes.
15? 1-5? Oh, very short time. The topic is very big actually, but I will make it short for the most important complications that develop during surgery or just after surgery, because it's good for you to remove the tumor or to totally resect the tumor, but it's very bad for the patient if he dies from diabetes insipidus. That will ensue shortly after your surgery. And this is a very, very common complications, as you know, and I think you are struggling with treatment of those conditions. Those conditions actually must be treated in collaboration between neurosurgery and anesthesiology and pediatric endocrinology and pediatric intensivist people. Yes. Okay, good. You have, mashallah, yani a good technician, people. Thank you. Okay. It doesn't move. خلاص هذا ما يمشيش. طيب, okay. So in cases of craniopharyngioma, those presentations usually come at presentation. As you see here, the growth hormone deficiency comes in the first. Around 70% of people with craniopharyngioma have growth hormone deficiency before you touch the patient, before even presentation to your clinic. LH-FSH deficiency also present in more than 50%. Central diabetes insipidus is almost in 30% of patients. Central hypothyroidism in more than 20%, and the most dangerous one is ACTH deficiency, which is central adrenal insufficiency, is present in more than 10% of people. Okay, this is a retrospective study from sick kids in Canada, Toronto, Canada, and this study showed that the trend of craniopharyngeal surgery affect the long-term complications in terms of endocrine issues. So with gross total resection that has been decreased now in a time between 2000 to 2011 is being done less than it was before. And in the same time, you see that the subtotal resection is being done more frequently than it was done before, and the cyst decompression is being done even more frequently than before. With this, the endocrine complications in terms of anterior pituitary deficiency or anterior, any pituitary hormone deficiency or anterior pituitary hormone deficiency or central diabetes insipidus, obesity and severe obesity comes with less destructive surgery done for craniopharyngioma. Okay, what are the post-surgical endocrine complications? They are early post-operative complications, which are the most important for you. You need to know, and long-term complications, which can be dealt with, by pediatric endocrinologists. So early post-operative complications can range from hypernatremia to hyponatremia, and from severe dehydration to overhydration. The hypernatremia causes mostly are diabetes insipidus and inappropriately fluid therapy and adipsia, while hyponatremia is being caused by CADH or syndrome of inappropriate ADH secretion, cerebral salt wasting, and many other less frequent causes. Okay, while long-term complications are hypopituitarism, which comes in the first, and increased cardiovascular disease risk, hypothalamic damage, and hypothalamic
It's the first time I've ever had to use the WhatsApp during a conference.
many
I'll call you back.
other complications that affect those patients.
Meanwhile, watch
after
it
surgery.
on the internet, okay?
Okay, we'll speak now about the most disastrous. I think this is the nightmare for any neurosurgeon after after any craniotomy, actually, not only craniopharyngioma surgery. So the hypernatremia that is being caused by diabetes mellitus or inappropriate flow therapy or adipsia. Now, diabetes insipidus can be transient, permanent, or as a component of triphasic pattern. And this is the triphasic pattern. The phase 1 is ADH deficiency. Phase 2 is hyponatremia due to excessive ADH release, actually. And phase 3 is permanent central diabetes insipidus due to permanent loss of ADH producing cells. How can you diagnose diabetes mellitus? These are the criteria, the diagnostic criteria. All criteria must be present to diagnose the patient. Serum sodium is more than 145, serum osmolality more than 300, while urine osmolality is less than 300, and urine output is more than 2 liters per kg per day. And you might use 4 ml per kg per hour. If the urine output is more than 4 ml per kg per hour, then this patient has polyuria and he might have central diabetes insipidus. The patient must be monitored pre-operatively, intraoperatively, and post-operatively for the development of diabetes insipidus. And you should always rule out other causes of polyuria as osmotic diuresis like mannitol or Lasix or hyperglycemia. Okay, what are the treatment options you have for a patient with diabetes insipidus? So you have 2 arms for treatment. The first arm is vasopressin injection, IV infusion actually. And the next arm is fluid management. So you should manage the patient of central diabetes insipidus by these these two means of treatment. For vasopressin infusion, you should, this is just suggested infusion or suggested mixing up, how to mix up the vasopressin. You should dilute 10 millunit in 500 ml as you see here. And you should start the vasopressin infusion at a dose of 0.1 to 0.5 millunit per kg per hour. And then slowly you can increase or decrease the rate until you reach your goal of urine output. What is your goal of urine output? Is to be less than 2 ml per kg per hour. So you should monitor the patient closely every 5 minutes, and you should adjust the dose of vasopressin accordingly. If the patient has not responding to 4 millunit per kg per hour, then you have to recheck your IV for patency and check the infusion preparation and rate. Okay. What is the fluid management during vasopressin infusion? Once you start vasopressin infusion, then you must not replace any urine output with additional fluids. This is a very, very important point you have to remember anytime if your patient has been started on vasopressin. And appropriate fluid is generally dextrose 5% normal saline. You might increase the dextrose to 10% if the patient has hypoglycemia, and you might start insulin infusion if your patient has hyperglycemia. You should add potassium chloride as needed, according to blood potassium level. And you should keep the total amount of eye fluids at 2/3 the maintenance. Any replacement of blood loss should be done by normal saline, ringer lactate, albumin, or blood product as appropriate. And you should check the serum sodium every hour. Every hour, sodium should be checked until the patient is stable. Once he is stable, then you can space the checkup of serum sodium to every 2 to 4 hours. And you should do serum osmolality every 4 to 12 hours. The urine output, of course, should be monitored every hour. And the dose of vasopressin should be adjusted according to your urine output. what we have said about the urine output should be less than 2 ml per kg per hour. If your patient has oliguria, then you have to decrease the vasopressin or stop it. If he has persistent oliguria, then you have to assess his fluid status and you might give him eye fluid as needed. This is the chart I am personally use actually. This done by me. This is I use this chart for any patient in ICU during vasopressin and fluid management. It contains all criteria that you need to monitor during treatment with vasopressin and fluids. Once the patient once the patient is able to take orally, then you should stop vasopressin and start sublingual or oral desmopressin after ensuring that the patient has clear signs of polyuria. You should not just stop vasopressin, then start desmopressin unless the patient has urinary breakthrough and polyuria. The dose of oral or sublingual or nasal desmopressin should be adjusted to keep the urine output less than 2 liters per kg per day. What is your patient is having adipsia. Adipsia means loss of thirst sensation. إذا ما بش عنده عطش. تمام. So those patients are actually quite difficult to be managed, because if your treatment is not optimal, then the patient will cover the deficiency by ingesting more amount of water. But
yes, hi, is this Michelle?
But if your patient is adipsic or has loss of thirst sensation, then you have to manage him in a little bit different way. These are the management guidelines. You should give him a fixed desmopressin dose that allows for minimal urinary breakthrough in between the doses, and timely diaper weight-based replacement of water. Body weight should be measured twice a day and should be corrected by fluids. And you should provide the nutritional and water requirement. Actually, I have a good experience on those conditions, and I have suggested my guidelines of treatment in this article that has been published in 2021. You can download it from the American Journal of Case Reports for free. Okay, there's another. Come. 1 minute. Okay. So. This is the most important actually complication. There are many other acute complications just after surgery, including SIADA and cerebral salt wasting. Those are managed in a little bit different way, but the most difficult one is central diabetes mellitus. In terms of long-term complications, the most important complications is hypopituitarism that might include growth hormone deficiency, ACTH deficiency, TSH deficiency, and gonadotropin deficiency, of course. For ACTH deficiency, my message to you is to give the patient a good dose of hydrocortisone or dexamethasone before surgery. Otherwise, if your patient has central adrenal insufficiency, then he might die on stage while you are doing your surgery. This is counseling for any patient who is having ACTH deficiency. He should bring this. I have this for. I give it to every patient of mine who is having adrenal insufficiency, either central or primary. Okay, if the patient has acute adrenal crisis, you should give him a good dose of hydrocortisone and fluid replacement. In case of growth hormone deficiency, and this is a very common presentation because they come in short stature, we deal with those patients with replacement of growth hormone. And you know that growth hormone is very important even for adults, even for bone health and for general well-being. They need growth hormone, even if he is adult. Yeah, it's not necessarily to be a child to be given a growth hormone. Adult patients have also, like Messi has growth hormone deficiency, congenital growth hormone deficiency, and he is being treated actually until now by growth hormone. This is just for to remember something that is important for those patients. Regarding TSH deficiency, you should replace with L-thyroxine. For LH and FSH deficiency, you should induce puberty at a proper time for both sexes, either male or females. And the hypothalamic obesity. This is my take-home message. Craniopharyngioma surgery is associated with fatal complications that must be addressed closely. A proper collaboration between neurosurgeon, pediatric endocrinologist,
is crucial for management of any case of craniopharyngioma. The patient should be assessed by pediatric endocrinologist before, during, and after any craniopharyngioma surgery. And thank you.
Thank you very much, Dr. Anas.
Thank you very much, Dr. Anas. Thank you very much. John, do you hear me, John? John? John, can you hear me? Professor Podolsky, can you hear me?
Yes, yes, I can. Yes. You're supposed to have received the Did you receive the PowerPoint?
No, I can't. You try, doctor, to try share screen button, green button.
Yes, I can share the screen. This is not a problem for.
Okay.
But
Share the PowerPoint presentation.
Share. Nothing happened.
You cannot see your presentation, Professor.
Okay. Okay. My presentation is open on my computer, and I try to share it. I just press the button, share it, and it doesn't work. Share screen again.
Okay.
Share. Open system preference.
Okay, does the screen open up after you click share?
Yes, yes, there is a screen.
Okay, and you click on that share button, and what happens?
Okay, it's written here, open system preferences.
Okay.
And if I do this, I have.
Okay, I don't think this is going to work. You need to send me the file. Do you have any children around that can show you how to send a file?
Okay, yes, but I sent.
You have any children there to help you send a file?
Okay, but
anybody around there?
Yes, I sent the file to one of the attendees.
Yeah, I gave you 2 email addresses. I've received.
And I sent it twice to.
Yeah, I don't know why, but I'm not getting them.
And I have the confirmation. I have a confirmation that you received.
Okay, I'll look again. I hope it came.
Yeah.
Oh wait, I got it.
Yeah. So.
Okay, hold on.
Okay, I'm really sorry about that.
No, it's not your fault. This happens all the time. Man, oh man. I don't see any attachment. Wow.
Receive it? Did you?
No, I don't see. Did you attach the PowerPoint? I can't, for some reason, I can't see an attachment on you, on your, I don't know why. Did you attach the PowerPoint to that? Could you try again, please?
Yes, I did twice, by the way.
Yeah. Well, I'm getting an empty email, so that's not working.
It took 7 minutes to send it because it was too heavy. So.
Oh, it's too big. Maybe
so
that's why. Maybe that's why. Maybe that's why.
Yeah, but I sent it to another participant. He might he receive it.
Hello. Yeah. Hi. Could you try to send the file without? Okay. Could you please email? Did you get my email addresses?
Yes, I have. I tried it for the 5th time. I would try to send it.
No, send it by email. No, don't send it by the chat on the. You can try it, but you can also send it. Try about 5 different ways to send it. Okay, send it by this email and send it by a couple other emails. Yeah.
I send it in 3 ways. One is using the TV something, the address. JP.
Yeah, that would work. That would work. Okay,
Yeah, I
where are
did
you in the
that, and
panel? Are you in the webcast now?
What did you say?
Okay, the complete name, please. Begin with C. Oh, Khalil, right? Okay, I'm gonna let you in, then you can share the PowerPoint. That would work. Are you in there? I gotta get you in the panel here. That'll work. Okay, you're coming in. Okay. I'm glad to see the audience is still waiting. We're working on it.
John, you hear me?
Yeah, Michelle, I think
Yes.
we got an answer. I think okay, there you go. Just
Yes, exactly. Yes, this is perfect.
just instruct Michelle when to change the screen, okay? Perfect. Go ahead. Go ahead, Michelle.
Okay, so I really apologize for this. I have to try to understand tomorrow why it didn't work. Okay,
Don't worry
but
about it. No problem. No problem.
So anyway, so good morning, everyone. It's really my pleasure to be with you today. I would like to thank warmly Dr. Al-Juhadi and the members of his organization for inviting me to this conference. So the main goal of my presentation is to highlight that this supracerebellar transtentorial approach, or what I will call it SCTT, is an excellent method in certain cases for reaching the supratentorial lesions, including vascular lesions. This approach has advantages, and I will illustrate this in the next, please, next slide, please. So you see this, for instance, this medial temporal meningioma. If you try to reach this lesion via a transtemporal approach, for sure you have to transgress by definition the neural tissue with injury of the optic radiation and injury of the speech area if you are on the dominant side. If you want to approach this lesion via a subtemporal approach, you have to retract a lot in order to reach this lesion, and you are more likely to produce contusion and injury also to the optic radiation and again to the speech area if you are on a dominant side. However, as you can see, you can approach this lesion directly without transgressing any brain tissue if you go by the SCTT approach. So this approach, next slide, please. Thank you. So in 1976, Yazagil published a case of medial temporal cavernous malformation using the SCTT approach. But since then, next slides, Khalil. So since then, numerous cases have been published using this approach, as you can see in this case. Next slide, please. And I even could approach a lesion. This is a meningioma without a dural attachment in the left atrial, in the dominant side of the atrium, that we could approach successfully with this SCTT approach. So my presentation today, next slide, yes. My presentation today will focus on using this approach for vascular lesions affecting the following three compartments. First, the temporal lobe, and do you see my oops?
Yes.
Do you see my pointer here? So the three compartments.
No, not really. No.
Okay.
Can you move it again, please?
But I see Khalil moving it.
Yeah. Okay.
Do you see
are.
that? You
Yeah,
don't see
it's moving. It's moving.
Okay, so
But,
how come you can see my you cannot see my slide, but you can see my anyway.
right, right.
Okay, so this is the temporal lobe. This is the first compartment. So I will show you example of approaching vascular lesion in the medial temporal lobe, also in the tentorial, in the incisoral space here, and next, also the third compartment is the brainstem. In order to do this, can you go back a slide? Okay. In order to do this, of course, you need to know the anatomy. Not only the microsurgical anatomy, but also the functional anatomy of the temporal lobe, of the brainstem. You need to know, you need to understand the anatomy of the arteries in this area, and also to the veins. Please, next slide. And of course, you need to understand the anatomy and of the tentorium, especially of the tentorial sinuses. Okay, so I like to do these approaches using the park bench position. Image guidance is essential for these approaches, and we use the SSEP and MEPS for especially for, of course, for it's very important, especially for the brainstem lesions. Next slide. So this is how, just a very short video to show you how we approach. It's a park bench position. We open the cisterna magna in order to relax the cerebellum. We expose the tentorium. Most of the time, the tentorium in its middle area, in the middle portion, is almost avascular, and we can expose the supratentorial area, including the temporal, the basal temporal lobe. Next slide. Next. Again, next. Thank you. So one slide. Can you come back for one slide? Another. Okay. This one, yes, thank you. So I will show you example of each of these compartments. So this is a 27-year-old patient who presented with a mild rupture of this, mild bleeding of this AVM located in the medial and posterior temporal lobe. Of course, if you approach this, again, this is on his dominant side. If you approach this lesion via a transtemporal route, more likely he will have some kind of speech difficulties, some kind of aphasia, and of course, since you are going to this, you will also affect his visual field. So next slide. So what we did, this is the angiogram, because the angiogram showed that this is mainly vascularized via the posterior cerebral artery, the branches from the PCA. Next slide. Okay, thank you. So you can see that the AVM was partially embolized, but we still have a significant amount of the residual AVM. So we use this approach to remove the lesion. Next slide. And now you see this is the post-op angiography, which reveal no shunt, and you can see that the brain is intact. The patient has no speech difficulty, and his visual field is intact. Next slide. This is another example of a rupture AVM. This is at the posterior part of the hippocampal gyrus on the right side. You can see on the angiogram on the left side the small aneurysm. Just no, on the other side, other image. Can you? Yes, here you can see the small aneurysm. Not here, more on the left. I'm sorry. Can you see my here? You can see the small aneurysm and the AVM here. So what you can see also this transmedullary venous drainage, in addition to this to the very early opacification of the straight sinus here. So we decided to embolize this the AVM and especially the small aneurysm, which was responsible for the bleeding. But still, after the embolization, you can see that there is still this transmedullary vein here on the. You can see this on the lateral view on the right side. And this is the post-op, which revealed no residual AVM. Next slide. And again, you can see the CT scan and the MRI the post-operative MRI, which we can see with this that the patient is doing very well. Next slide. So this was for the temporal lobe. Now this is on the incisoral space. This is the location for very rare aneurysm, located especially at the junction of P2 and P3 portion. Okay, so this is very accessible via this approach. You can nicely have the proximal control of the P2 segment before the aneurysm. And with this approach, of course, above the fourth cranial nerve and opening the dura, you can reach this aneurysm. So please, so this is the example here. This is a 42-year-old female. She presented with a thunderclap headache 2 days prior admission. And she has no neurological deficit. You can see the very mild subarachnoid hemorrhage on the quadrigeminal cistern. You can also see on this angio-CT the small aneurysm, and this is confirmed with the angiography at the P2, P3 junction on the left side. This is a dominant side. So, of course, please go back again, Khalil, please. Okay, okay. So, of course, this aneurysm can also be treated by endovascular means, but the way to treat this is most of the time the risk of occlusion of this area is most likely they will occlude the PCA at this level. Probably most of the time the patient will tolerate that, but we have report that that patient sometimes may have a stroke. That's the reason why we decided to approach. We treated this aneurysm by surgical means. Please, next slide. So this is the approach. So again, park bench position on the left side. This is the left side opening of the cisterna magna in order to relieve to drain the CSF and to relax the cerebellum. We use the neuronavigator after opening of the tentorium in order to localize the PCA proximal to the aneurysm in order to have a proximal control. I apologize for this video which is oversaturated. So this is the clip on the proximal control before clipping the aneurysm. It's a little bit, it's not fluid. I don't know why. Okay, and now we clip the aneurysm. You don't see it very well here, but you will see it later maybe. It doesn't flow very well, the video with this method. Okay, so the aneurysm is clipped. We are removing now the temporary clip. And you can see the aneurysm. Whoops, what happened? It doesn't work. No. Okay, next slide, please. Next slide. Next. Okay, so this is the pre-op, and the post-op. So you see the angiogram reveal complete occlusion of the aneurysm, and you can see that there is no transgression of brain tissue with this approach. And okay, next slide. This is another similar case with a very small aneurysm, not selectively treated, cannot be selectively treated by endovascular means. That's the reason why we decided to go by surgery. And again, okay, next slide. And again, you can see the suboccipital craniotomy on the retrosigmoid craniotomy. Here, the clip, and no sign of manipulation of the brain on the side, neither on the cerebellum. Next slide. So, next slide. Khalil?
Yeah, we're already in the next slide, sir.
I don't see it. Okay. Okay, I'm sorry. Okay, so we saw the first we saw example for the temporal lobe. We saw example for the incisoral space, and now for the brainstem. And here, of course, we are talking about the midbrain. So this is a 30-year-old female. He presented with the significant hemorrhage. This is a midbrain and thalamic hemorrhage because of this cavernoma. The patient was very drowsy, mostly because of the hydrocephalus. So even after external shunt, she still was very drowsy with weakness on her right side, and partially third cranial nerve, and the numbness on her Yemeni body. So this is the this is urgent. I like to do these things, especially when they are large like this. But any occasion, I think it's more easy to operate on these patients very early when it's possible, and you will see with the video why. So we use again with the supracerebellar transtentorial approach in order to reach the safe entry zone. In this case, the lateral mesencephalic fissure. Please, the video next. I don't see. I don't know. Okay, no. Khalil. Can you show? Yes. So again, the same approach. Okay, you see the fourth cranial nerve, opening of the tentorium, fourth cranial nerve. We will work above the fourth cranial nerve. Okay, this is we confirm the position of the lateral mesencephalic fissure. Small opening of the brain stem because the cavernoma didn't, despite the size, didn't reach the surface. And really, okay, so since it's a very acute surgery, we first drain the liquid portion of the hematoma, and then because it's an early surgery, it's much easier to remove this cavernoma with the clot, respecting the viscoelasticity of the tissue. You can see that most of the surgery is done with the instruments outside of the brainstem. I guess it's because of the internet, the transmission, that we cannot see it with this video with much fluidity. But again, so removing of this cavernoma with the blood, with the hematoma, and inspecting that, making sure that everything is gone. Okay, so this is this next slide, please. Next. So this is the day after the CT scan, with complete drainage of the hematoma. The patient improved quickly. As soon as she woke up, from the anesthesia, we could see a significant improvement. Next slide. This is the MRI a few months later. 2 years later, the patient was pregnant and had a nice, and she's normal. She has a good life now. Next slide. And the last case for for last example, this is a AVM, rupture AVM. The patient bleed from this at the posterior part of the midbrain, and this is due to small AVM located at the posterior part of the midbrain. Please, next slide. Okay, so you can see this. You can see the early venous drainage on the angiography, and you can see at the end, just before the straight sinus, there is a stenosis of the sinus, explaining why probably the AVM bled. So again, this is a very nice lesion to approach via the SCTT. Okay, so opening of the tentorium, reaching the area, guided by the neuronavigator, and this is the post-op. You don't see anymore this early venous drainage. The patient remains with the Parinaud syndrome. Her numbness on the opposite side was improved, but still she has a little bit of a problem with hypoesthesia. So this is the small series that I have for these approaches. For AVM, one posterior mesencephalic, one posterior hippocampal, two at the basal temporal cortex, three mesencephalic thalamo mesencephalic cavernous malformation, and two aneurysms located at the junction of P2, P3 segment of the PCA. There was no neurological decline in any of these in these patients. So in conclusion, SCTT offer a direct approach for selected vascular lesion located in the mesobasal temporal lobe, in the middle and posterior incisional space, and on the brainstem here, the midbrain, and allowing minimal manipulation and retraction of the brain. Thank you very much for your attention, and I apologize again for be responsible for the delay in the meeting. Do you have any question or? I cannot hear you.
Dr. Al-Jaradi, you are muted. Can you unmute yourself, please?
Hello?
You can hear me now?
Okay.
Yeah, we can hear you.
Thank you very much for that magnificent lecture. You can hear me?
Yes, I can hear you.
Thank you very much. Please, if anyone have any question, ask in the chat, and Professor Bobrovsky, maybe he'll try to ask you to answer you in the chat. Thank you very much, Professor Michel Bobrovsky. Now we'll move on to our next speaker, Dr. Mujahid Masar.
Thank you very much, everybody.
Dr. Mujahid.
Thank you, Prof. Banovsky. Thank you so much for the interesting presentation.
If anyone have a question for Professor Bobrovsky? Do anyone have any question? دكتور مجاهد موجود ولا لا؟ دكتور خليل.
Yes, Dr. Ahmed.
Have any question for Professor Bogonowski?
I'm checking the chat. I don't find any questions, but maybe from the audience, do you have any questions?
Okay, thank you.
Okay, thank you very much, everybody.
Okay, thanks a lot.
John? John, can you hear me?
Yes.
Do you solve the problem with the link?
Yeah, I think it's your form that you made. There's a problem with that. Could you check your form, please?
I checked it already, and when I tried to enter and
Yeah,
join,
I did not give out a link. I gave out the address to your form. Is there a problem with your form?
the form is working good, but
Yeah, you gave out a form. You didn't give out an email address, or you didn't give out a link.
the problem is in the link already.
Yeah, send me the link that you sent to people. That could be the problem. Yeah, Yemen Cloud, that could be the problem. Your link. Okay, I'm gonna check.
Dr.
Hold on, let me. I'm still checking.
Dr. Enos. Okay, we'll move on to our next speaker now. Dr. Enos, you can present your speaker now until we figure out the problem with the link. John, please find the problem with the link. Until now, we will start with our next speaker, Dr. Enos. And when you find a new link or figure out what is the problem with the old link, please let me know, okay? Do you hear me, John? John, can you hear me?
Yes, I can hear you.
We move to our next speaker, and please, meanwhile, try to figure out what is the problem with the link. Because when I press on join webinar, it tells me the webinar is already expired. And we had still had many speakers online. So this is a big problem. Dr. Enos, when you're ready, please start.
دكتور ايناس جاهز؟
دكتور ايناس جاهزة ولا لا؟
Okay, Ahmad, what are we doing here? Yeah, I can see the link is not working for some reason. Why don't you take a break? Take a break, and we'll come back, okay? I can see the link is not working. Are you taking a break now? Hello, Ahmed, are you taking a break now? Hello, Ahmed? Can anybody hear me? Hello, testing 1, 2.
Also, it contains the optic nerve, which passed from at the orbit from the eyeball to the brain. Okay. There is a lot of tumors started at the orbit. As we said, it has a lot of structures. Okay, these tumors, for example, which originated from Schwann cells called schwannoma, from meninges called meningioma, from the glial cells, optic nerve glioma. Also, it contains we have also another tumors that started inside the bony socket from the muscles like rhabdomyosarcoma, from the blood vessels like lymphangioma, hemangioma, from the bone itself, osteoma. The object of the study to determine the prevalence, presentation, and approach of orbital tumor, and to evaluate the outcome of patients who have undergone orbital tumor excision in the University of Science and Technology Hospital, Sana'a City, Yemen. Actually, the study was between December 2019 to October 2023. The specific objective of the study is to identify the age of the orbital tumor, number one. Number two, to identify the mode of presentation of the people who admitted with the orbital tumor. Number three, to identify the neuroimage that help us to diagnose patients with orbital tumor. Number four, to identify the types and approaches of treatment, surgical treatment. Number five, to assess if the patient has a palliative treatment after the surgery or not. Methodology of the study. Study design, it was a prospective study done between December 2019 and October 2023. Study location was at the University of Science and Technology Hospital, Sana'a City, Yemen. Study population, all cases of orbital tumors that admitted at neurosurgical department and underwent surgical operation. Sampling method and sample size, there were no sample size to be taken as we took all the cases that admitted to the department. Data collection, a structured questionnaire was administered to assess the orbital tumor. We take the study variations, informations about the patient himself, patient age, patient gender, and information about the disease, date of registration, symptoms, signs of the patient, and investigations done, and final diagnosis. Also, we take in the questionnaire information about the surgery, the approach of the surgery, and the post-operative palliative treatment. Data processing, all variables were reviewed and entered the computerized data analysis by using SPSS statistic 26 version. P-value were computed for categorical variable using chi-square, and the p-value was less than 0.05, was considered to constitute a statistically significant difference. Ethical issues, agreement from the participations of the patient and or the relative, answered the questionnaire by asking them, do you want to participate in this questionnaire? And they all were agree. All name and personal data of the individuals involved were kept confidential and will be only used for the sole purpose of the research. Limitations. Actually, the limitations we noticed in this study that we have a lack of previous studies, whether in our country or in the nearby countries. Number of patients also, this is a rare tumor. So number of cases was very small. Results. The result, we during 4 years, as we said, from December 2019 to October 2023, there were 12 cases admitted at the department. Number of cases was divided between male and female. 50% were male and another 50% female. According to the age, more than 18 years was 67%, while less than 18 years was 33%. The left eye was affected more than the right eye, as the left eye contained 67%. According to the symptoms that the patient admitted with, proptosis was 91%, pain, followed by pain, 25%, and then burning sensation, headache, visual field defect was about 17%, and then followed by local light limitation, burning sensation in about 8%. The neuroimaging we used to know the diagnosis and confirm the diagnosis, we used CT and MRI in 92%, and we used only one CT in 8% of cases. Most of the cases was of primary type, as it shows 67%, while in secondary type, 33%. Now about the type of the tumor, most of the cases which shows optic nerve glioma and non-Hodgkin lymphoma, about 17%, and then followed by cavernous hemangioma, glioblastoma multiforme, meningioma, osteoid osteoma, rhabdomyosarcoma, and sclerosed schwannoma, and they show 8%. The procedure that we take during the operation, transcranial superior orbitotomy was 67%, while lateral orbitotomy 25%, frontotemporal with lateral orbitotomy 8%. During these cases, we have only 17% that the nerve was inside the optic nerve glioma, and all these cases, the 17%, which shows 100%, we remove the optic nerve. According to the palliative treatment, only 17% of the cases had the palliative chemotherapy and radiotherapy after the surgical operation. Improved 83% improved totally after the operations, and we still follow them until now. While 17% they had a recurrent mass, and they're still on treatment. Discussion. Actually, related to our study, we have 12 cases in 4 years. Sorry, in 4 years. We have another study which is in Turkey. In 5 years, they have 14 cases. Another study in Poland. During 23 years, they have only 122 patients. Another study in Portugal for 9 years, they have 71 patients. In USA, another study showed 950 consecutive patients in 25 years. Another study in Montgomery shows 1,264 cases in a duration of 30 years. In our study, we show that orbital tumor shows 50% was female and 50% were male, and 67% of the orbital tumors affected the left eye. It shows near results to other studies, which is in Poland, 58% was in the left eye. In Turkey, was 57% was female, and in Portugal, 65% of patients were female. In our study, proptosis showed 91.7% of the symptoms of the study. It shows also near results to another studies, which shows in Turkey 100% of cases. The most common symptom was proptosis. Also, in our case, we take the investigations that we done for the patient. 92% we did MRI and CT, while 8% we do CT. In another study in Turkey, they did 100% CT and MRI for the patients. In our study, the optic nerve glioma and lymphoma was the most affected, was the most type of tumors, and it shows nearly results to other studies, as As in Portugal, the most common cause was extracorneal malignant lymphoma, shows 11%. In America, the cyst was 23%, followed by optic nerve meningeal neoplasm, 17%. Now the conclusion. The most common clinical presentation was proptosis. The most common type was lymphoma and optic nerve glioma. Most type of orbital tumors was primary and benign. Transcranial superior orbitotomy was the most common approach of orbital tumor excision. Most cases improved totally after the operation. Recommendations. Actually, at the beginning of the study, we chose 5 cases in 4 months, and then the number of cases was decreased. And then another time, for example, after I admit the abstract to the conference, we have 3 cases. Today was the 3rd case. So there is an increase in number of orbital tumors. So we want to show that there is increase in orbital tumors and give it more concern to the interested class in health sector in our country. Encourage the health organization to increase the concern about this increasing problem in Yemen. Also, we want to encourage and support other researchers to know about the causes and the reason that there is increase in the orbital tumors in Yemen. Thank you.
Thank you very much, Dr. Anas.
Actually, I want to add something. Actually, I just wanted to add something. This is my last patient. Her name is Asma. She wanted to say hello for everyone here.
شكرا. شكرا جزيلا دكتور أنس. والآن يتم الترحيب بجميع الحاضرين. أترحب ولا عادك؟
يبقى لكل فعالية ولكل مؤتمر نكهة خاصة عندما يكون على رأس حضورها دولة رئيس مجلس الوزراء الأستاذ الدكتور عبد العزيز صالح بن حبتور، الذي حرص على أن يكون جزءا لا يتجزأ كما عهدنا من هذه الفعالية المتمثلة بالمؤتمر اليمني الخامس لجراحة المخ والأعصاب العمود الفقري. وكذلك الأستاذ محمود عبد القادر الجنيد نائب رئيس الوزراء لشؤون الرؤية الوطنية. كما لا يفوتني أن أرحب بالأخوة والأخوات الحضور جميعا. الدكتور مجاهد معصار رئيس، تحية للحضور، رئيس المؤتمر ورئيس جامعة 21 سبتمبر، والأخ نائب رئيس المؤتمر الدكتور خالد بن ماضي ابن حضرموت البار، والأمين العام الدكتور مجاهد عامر، والأخوة والأخوات شهادة المخ والأعصاب ورؤساء الجامعات. الآن نحن وصلنا إلى من محاسن الصدف أن تكون المحاضرة القادمة هي للدكتور مجاهد معصار. أترك قلم لباريه والفرس لفارسه للجنة لتقديم الورقة التالية.
دكتور مجاهد مسار. دكتور مجاهد مسار, Senior Consultant Neurosurgery, member of Neurosurgical Society, General Secretary of Yemeni Neurosurgical Society, head of 21 September University for Medical and Applied Science, Yemen, Assistant Prof of Neurosurgery, Sana'a University. And 21 September University. Yes.
لا ما بيشتغلش. خفيف صح؟
بس الشجرة
في الشاشة ما بيطلعش.
هكذا
تقري يمين.
يمين ايوه يمين اليمين تقلب يمين تمام. شوف البوينتر هنا في الطرف.
بس ما بيظهرش. السلام عليكم ورحمة الله. أسعد الله صباحكم جميعا، ونرحب مرة أخرى بدولة رئيس مجلس الوزراء الأستاذ الدكتور عبد العزيز صالح بن حبتور، والذي يرأس شيخ الأكاديميين اليمنيين في كل محافظات اليمن، وكذلك الأستاذ محمود الجنيد نائب رئيس مجلس الوزراء لشؤون الرؤية الوطنية، وكافة الحضور طبعا كل بصفته واسمه وشخصه. ونشكركم على التفاعل ما شاء الله القاعة ملان اليوم. أبدأ محاضرتي. بسم الله الرحمن الرحيم. Good morning everybody. We will discuss today هو هذا ما ادري انا. طيب فنبدأ. I will discuss today is a rare case which is called the giant cerebral cavernomas, a case study that was prepared by me and operated also too with Dr. Ismail Al-Houthi. The giant cerebral cavernomas, I will do the introduction and the case report we'll discuss today, the conclusion, then questions and discussions. We have also a question at the last. Cavernoma is also known as, it has too many different names, called cavernous malformation and cavernous hemangioma, to cavernous angiomas, but we call them cavernomas briefly. The definition, as you see, the pointer is not working well by this in the screen, but defined as well circumscribed, multilobulated, angiographically, which is character of this lesion, angiographically occult vascular malformation. You can see in this picture of MRI and anatomical diagram. Characterized by lacking of intervening brain parenchyma. Pathologically, as we see this picture, composed of endothelium lined thick and thin-walled sinusoidal vascular channels located within the brain tissue. Epidemiology of these lesions, based on a large autopsy and MRI series cavernoma developed in 0.02 to 0.013 of the population. The CNS or brain cavernomas accounts for 5 to 13% of all intracranial vascular anomalies located in the brain. The size of cerebral cavernomas differs from small size to large size, vary in size from few millimeters to few centimeters in diameter. As we see in this picture of MRI, this is a small one and this is the large one, which is giant. Giant cavernoma, as you see in the MRI by measurement, is defined as a cavernoma with a diameter more than 4 centimeters preoperatively in MRI pictures. Giant cavernoma in worldwide in population, in the history of neurosurgery, we just find in literatures 65 cases
of cerebral giant cavernomas have been reported in the literature in the last 62 years, and we find the 66th case in Yemen. More common in children more than adults. And this giant cavernomas, because of the size and picture in MRI, misdiagnosed as other intracranial neoplasms. المهم راحك محمد جميل دخلت صبوح بالحين. May be diagnosed as intracranial neoplasms, differential diagnosis, and شو صبحوا we should concentrate on this differential diagnosis because we have a quiz at the last of this lecture or this presentation. Differential diagnosis including pilocytic astrocytoma, as you see in this picture of MRI, the right side, hemorrhagic metastatic tumor. طبعا انا بمشي الصور بسرعه علشان السؤال ما تقدروش تحلوه في الاخير. Hemorrhagic metastatic tumor, low grade malignant cystic glioma. السؤال عليه جائزه طبعا احسن من الصبوح. Low grade or malignant cystic glioma, primitive neuroectodermal tumor, as you see in this picture on the right side. You should compare to answer the question at the last. And oligodendroglioma, thrombosed AVM, the last is the spontaneous intracerebral hematoma. Presentation, clinical manifestations of patients. Most cavernomas are small and remain asymptomatic for long periods of time. Supratentorially, cavernomas will precipitate the new onset of seizures and headache. Seizures and headache, the manifestation of supratentorial located cavernomas, and the infratentorial cavernomas more typically lead to, which is characteristic of this lesion in the site, acute progressive neurological deficit, because mostly located within the brainstem. So it is typically acute neurological deficit. Presented usually by hemorrhage, recurrent hemorrhages of cavernomas. The evaluation of the case started by the CT scan. As seen in this picture, even you cannot recognize in the CT scan, but you can recognize it in which small in the MRI. The pointer is very vacant too. Not sensitive for small cavernomas, the CT scan, when you compare with MRI. Large cavernomas present punctate or large calcification. We will continue evaluation by MRI. The MRI T2 weighted images is the golden standard of this lesion to be diagnosed. As you see in this picture of MRI T2, this is popcorn. تنفعش. Heterogeneity of this picture due to bubbles of blood shown as popcorn-like mass. With hypointense rim of hemosiderin is a pathognomonic of it on T2 weighted images MRI because of resorption of blood with time. And this picture of MRI, you can see cysts reflecting various states of degradation of blood due to recurrent blood and resorptions. The management is the surgical excision is the best solution or treatment of choice. If there is recurrent hemorrhages, the indications of surgical excision, recurrent hemorrhages, progressive neurological deficit or deteriorations, and intractable epilepsy fits. And the last one is the lesion if located in accessible non-eloquent areas that you can access to this lesion easily without damage of brain eloquent tissues. The total excision should be attempted when the operation is considered. You should excise the tumor or the lesion totally. It is already dissected by itself due to hemosiderin and the rim of hemorrhage resolved around or surround the lesion. And we have another option of management or treatment by the stereotactic radiosurgery, SRS. The efficiency of radiosurgery in cavernomas remains uncertain because some studies show have possibility of reduction risk of hemorrhages after 2 years of SRS, the stereotactic radiosurgery techniques. This study is reserved for the SRS or indication of non-accessible lesions. Even in some centers, you can excise even in brainstem, non-accessible lesions in eloquent areas, deep located cerebral lesions or brainstem lesions. Stereotactic radiosurgery and the morbidity and latency period of RS should be considered because the efficacy after 2 years of management or treatment by SRS. Now we will start to discuss our case, which is the 66th lesion in the world, which was a 7-year-old female patient from Thais presented with new onset of recurrent seizures attacks, progressive left side hemiplegia, 1 month prior to presentation. She came with headache and seizures with left side hemiplegia. We do the CT scan. The CT scan after this clinical presentation done and showed this non-contrast CT scan revealed the spherical, slightly hyperdense intraaxial lesion at the right basal ganglia extended to the Sylvian fissure measuring 5 by 4.55 centimeters surrounded by moderate perifocal edema. Then for more evaluation, this is the CT scan with contrast, shows or revealing slight patchy enhancement as seen in this picture. The MRI with T2 show iso intense signal. T2 because of the size, it is a big tumor with the surrounding perifocal edema due to the hemorrhage, recently hemorrhaged, or and this is the contrasted T1 weighted MRI images show patchy enhancement. It's clear in this MRI. So we enter the operation with different differential diagnosis. Symptomatic right side Sylvian giant cavernoma. This is the conclusion. Decision of management is the excision of this giant cavernoma surgically, microscopically. During surgery, we found this cavity through the Sylvian fissure. This is held with for this child by Allah. The right frontal temporal approach is utilized, then through the Transylvian corridor is established, and this is the lesion post-operatively. Dark brown cavernoma after en bloc completely excised. Under microsurgical technique, which revealed a large dark brownish mass with distinct margins from the surrounding tissues. The lesion was totally resected in block. Post-operatively, she was conscious, alert, with no new neurological deficit apart from the pre-operative left side weakness or hemiplegia. This is the CT scan post-operatively. This is, you can see the defect because of the large size of lesion by CT scan. And this is the pre-operatively to compare between the two pictures, pre and post. Post-operative control CT scan, as you see. Then histopathology, this is the histopathology. Describe the findings of cavernoma or the lesion, which is described by our histopathologist. Variable size, dilated thin-walled blood vessels lined by a blend looking for flat endothelial cells. Revealing this multiple variable size thin walls, which is in summary is a cavernous hemangioma. Cavernous hemangioma is cavernoma, as we said. Post-op, follow-up post-operatively. This is the total excision, and this is the defect of the lesion. This is the pre-op. The patient follow-up after 3 months, she came to us and she's very well. Left side hemiplegia subside, great improvement. She's walking, she's talking, everything is okay. Still on anticonvulsant drugs, just. Conclusion, giant cavernoma is a very rare intracranial lesion, most predominantly in pediatric aged, the giant size, but the small size in the adults. Best diagnosed with MRI plus minus CT scan. Sometimes confirmation requires, it's always, I think, not sometimes, we need the histopathological examination to confirm the diagnosis and follow up the patient. It should always be included in the differential diagnosis of, this is the question it will come. Spontaneous intracerebral hemorrhages, large cerebral SOL, which is space occupying lesions, including a lot of lesions or tumors. Surgical excision of cavernoma should be decided for. The indications is, this is for our students and residents, recurrent hemorrhage and colleagues too. Progressive neurological deterioration, intractable epilepsy, lesions located in accessible non-eloquent areas in the brain. Total excision of giant cavernoma using microsurgical techniques carry good results and improvement post-operative outcome. كيف التايم يا أحمد؟ The case provides important points of practicing neurosurgeons to consider making differential diagnosis of large intracranial space-occupying lesions. Our case report is one of the rare reported cases of cerebral giant cavernoma. As we said, in the worldwide in the history of neurosurgery of the last 62 years, the total found lesions or giant cavernomas is 65. Our case is the 66th, 66th case in the history of neurosurgery worldwide in the last 62 last years. This is the question. How can you describe this lesion? خلصنا الأولى. And we have a new case of differential diagnosis. Concentrate on this lesion. Three different intensities in this. Our students and our residents and our colleagues. This is CT angio. CT angiogram shows this lesion. It's the same. CT angio and say this is MRI. This barcode by your telephone, you can see the question.
and choose the best answer. الجواب أنا يكون عندك.
الشباب افتحوا 3 جي معاكم سؤال تبع الدكتور على البرزنتيشن حقنا. اقرأوا الباركود الموجود أمامكم وجاوبوا مع نعرض النتيجة بعد شوي. معاكم دقيقة.
تصويت. الإجابة في الموقع. السؤال الباركود والسؤال يطلع بالديفرنشال دايجنوسيس وجاوب بعدين نحسب النسبة. اللي يركز على المحاضرة في البداية أكيد حيجاوب. ها؟ Online too, yeah. Our colleagues online on the Zoom, they can also make a scan of the code. وعليها جائزة للحاضرين طبعا مش للأونلاين. كم الوقت يا دكتور عبد الرحمن؟ This is giant child. Huh? خلال كم يطلع التصويت؟
ثواني الآن عرضة.
نوزع الصبوح إلا في محاضرة.
لا حتى الآن قد جاوبوا على السؤال 20 شخص 25 شخص.
اللي ما جابش ما يدخلش الامتحان حق الترفيعي. وخر الكاميرا ما بيظهر الديفرنشال دايجنوستس في السؤال طبعا عندك. choose the best answer. ركزوا طبعا الموضوع السي تي انجيو يعني له دور في الموضوع فما نتوهش انفسنا وكل واحد طبعا يطلع اسمه في الجواب.
الى حتى الان 35 باقي نص دقيقه.
ها خلاص بدون اسماء يلا بدون اسماء جاوبوا بس تصويت. اخي الميكروفون كسر.
الى حتى الان 40 طبعا اللي جاوب قادر يشوف حق هالاجابه اذا صح ولا غلط. في معاكم الجوال شوف اجابتك صح ولا غلط. طبعا يتم العرض فقط الاجابات الصح بدون اسماء. كم نسبه اللي جاوبوا صح وكم نسبة
بدون اسماء بدون اسماء لا تخاف. جاوبت خالد.
خلاص يا شباب الحين الوقت خلص.
See the blood vessels feeding the lesion artery.
طبعا انتهى الصبيان عدد حتى الان بيجابوا لحتى الان 38 اجابه صحيحه في معنى 13 2 3 الاجابات الخاطئه. التوتال 40 60 شخص يعني ما شاء الله نسبه الاجابه الصحيحه هي اللي بالاخضر. في اشخاص جاوبوا غلط اللي عباره عن الرمادي.
استفادوا من المحاضره فعلا لكن زي ما قلنا بري اوبراتيفلي وين حق العرض. عبد الرحمن رجعنا.
طبعا السؤال موجود فوق السبوت ديجنوسيس. الاجابه الصحيحه اللي عباره عن جاينت
كافرنوما.
ارجع ايوه خلاص ارجع المحاضره خلاص
ارجع المحاضره. So fortunately we found 67th case in the same I think 3 months in the same duration of 3 months. 66th and 67th case reported worldwide. The last two in Yemen of these 2 cases within 3 months. يعني if we are lucky, this is fortunately. طبعا preoperatively we see and this is differential diagnosis of a lot of diagnoses, but mostly I think or I thought me and my colleagues it was a thrombosed giant aneurysm, but intraoperatively alhamdulillah it was giant cavernoma with a huge blood collection around or surrounding it. Around this, even this misleading us, the CT angio misleading us that we think of
thrombosed giant aneurysm and then entered during operation. We were lucky to find it as a giant cavernoma and is excised. The patient is very well and recovered. This is a lucky child. شكرا جزيلا والسلام عليكم ورحمة الله وبركاته.
Thank you, Dr. Mujahid. Nice lecture.
Thank you very much, Dr. Mujahid. Now we'll move on to our next speaker, Professor Dr. Jyoti Bartiban. Is a senior consultant neurosurgeon and course director at National Board of Examination and founder, member, and foundation secretary of Neurospinal Surgeon Association in SSA, India. Dr. Bartiban, how are you?
Very fine. Thank you, Dr. Ahmed, for inviting for this auspicious Yemen Neurosurgery Society.
I cannot hear you, Doctor.
I'm very thankful to you, and I can share my screen for you.
Yes, please.
صوتيات شوف ايش مشكلة. Dr. Bartiban, we still cannot hear you, so please wait a second.
Are you able to?
We can hear you fine. We can hear you fine, Jody. Thank you.
Ahmed, I'm able to see you. Ahmed?
No, you hear me?
That's okay, Jody. You're fine.
No. Problem is from our side. Shabab, problem is from our side. We cannot hear the speakers.
Oh wow. We can hear.
But
Can you hear? Can you hear me? Can you hear me, Ahmed? Ahmed? Ahmed, can you hear me? Can you hear me, Jody?
Ahmed, are you able to see my presentation?
Yes.
عبد الرحمن.
Yes.
بيتكلموا الآن مش سامعينهم. هم الآن بيتكلموا احنا مش سامعينهم.
Jody, can you hear me?
وصلوا الصوت حق برنامج الزوم للقاعة يا شباب.
What the hell? Can anybody hear me, please? No, you can't hear me?
I'm audible?
Yeah, for me you
عبد
are.
الرحمن سعيد.
Can anybody? Jody, can you hear me? No. No.
Ahmed is not hearing you.
Okay. We still cannot hear.
John, I'm okay. John, are you able to hear me?
Yes, yes, I can hear you. Can you
But
hear
why-
me?
Yes, I'm okay with
hear
you.
me?
Yeah. Yes.
Wow. I don't know what's going on. Oh,
Are they able to see me, my
okay.
presentation?
People answer. Okay, you can hear me, right?
عبد الرحمن شوف ايش مشكلة.
Jody can't hear me. Can you hear me, Ahmed?
Yeah, they are seeing my slide, I think.
Okay, you can. Okay, great. Thanks for telling me. But apparently, Jody can't hear me, and Ahmed
Ahmed?
can't hear me. Ahmed or Jody, can you hear me?
Yes, now we can hear you. Finally we can hear you now.
I can't hear you. I can't hear you, Ahmed.
Thank you.
Are you able to hear me?
Now I can't hear Jody.
Professor.
But
Yeah,
everyone
thank
else
you
can
very
hear
much.
me.
Okay, thank
And
you
both
very much.
voices are clear. What is going on with Zoom today?
Okay, thank you very much for inviting
I can't
me.
hear you, Jody. I'm sorry.
I'm okay now. Can I proceed?
Zoom is acting crazy. The
Yeah.
panelists can hear me, Jody can't, and we can't hear Jody.
Can I start my talk?
I can see your microphone on, Jody. Can anybody hear Jody?
Yes, we can
hear Jody.
Okay, shall I proceed? Shall I proceed?
Yes, we see your screen.
Okay, can someone on the panel answer if they can hear me? Can you hear me or Jody?
I think
All
that
voices are good. Oh, okay.
okay. Right.
Proceed. Okay, Johnny, you can go ahead.
Thank you very much for inviting me for this very beautiful Congress of Yemen
Ahmed, are you
Neurosurgery
there?
Society. Yeah.
Okay,
You know,
would anyone like to take over as panelists?
yeah.
Do we have
John,
a moderator?
I'm starting,
Johnny
right?
can go ahead.
Yes, thank you. Thank you for inviting, and my talk is
such a mess.
I'm speaking on basal cystinostomy. Today, my talk is on basal cystinostomy, and we all know that the trauma is very important part of our specialty. Whenever a head injury happens, there are two things happen. One is vasogenic edema, and the other one is the cytotoxic edema. And it's a very big challenge because it starts with the medical management, and we go ahead with the ventilation, and then if needed, we go ahead with the surgical procedures. Now, the basic principles of ABC, osmotherapy, fluid considerations, mannitol, hypertonic saline barbiturates, temperature controls, and the neuromuscular blockades, they all being used to manage the cerebral edema, but nothing better than if there is going to be a mass effect, then you need evacuation of hematomas that are responsible, and like the EDH, STH, and ICH, and hemorrhagic contusions. Decompression of the concerned edematous cerebral edema and cerebellar hemispheres with wide and large decompressive craniectomy with dural opening is the standard of treatment so far. And we all see this very often. You can see very nicely the decompressive craniectomy, and you can see the way the brain bulges out to give a space to the brain so that the brain does not get compressed and you have midline problems. And so a decompressive craniectomy helps in expansion of the brain, but it does not provide what it does to the cerebral edema per se. To top it all, the basic treatments are followed in such a way that the CSF is the one which get accumulated at various places after the trauma, and the CSF need to be let out because the standard treatment sometimes after the decompressive craniectomy also, we do the external ventricular drainage for a long time. But there are many ways of draining the CSF letouts. Like, sometimes you can do the subarachnoid opening, so the sulcal regions, Sylvian cystonostomy, if it is possible in those cases. Otherwise, we have to consider the basal cystonostomy. The basal cystonostomy is not new. It is absolutely not new. It is a very old technique which is there for the neurosurgeons to see for more than 100 years, basal cystonostomy. Now, the classical teaching of the CSF is produced in the ventricle, and then it drains through the third ventricle, and then the fourth ventricle, and then the subarachnoid spaces, all around the subarachnoid spaces, and then get drained up in the superior sagittal sinus, and then it drained out. This is the best schematic that which we were taught, and we were also aware of Professor Dandy's experimental studies of one dog in there, where they found that the enlarged ventricles can be released by letting of the fluid of CSF, and that is being used so far. Now, after that, we started understanding about this Virchow-Robin space, and in the Virchow-Robin space, there are so many things happen. The transfer of the fluid from the Virchow-Robin to the CSF into the interstitial space, and this is the most biggest development which has come in the past 50 years, and we started learning much about the Virchow-Robin space. So what happens to the Virchow-Robin space is nothing but it is with the sulci, and through which the vessels and also the veins goes, and there is a disparity between the pressure gradient and the fluid goes from one side to another side. And this is now the recent advances have predict from this the regular flow. We have been taught to know about lymphatic pathway systems in the present era, where whenever this lymphatic pathway system, for example, a fluid comes from here and then migrates to the interstitial space and then get drained out. But what happens in trauma, if this system get damaged, then you get accumulation of the cerebrospinal fluid in the interstitial, that is the cerebral edema that can cause a cerebral swelling. And this cerebral swelling needs to be drained out. So this is the normal function of this lymphatic pathway. But in the head injury, during the injury, this get distorted, and this accumulation causes severe edema here. So this is now proved beyond doubt in many of the experimental studies by the Nethergaard, and I request and everyone to read these papers through this IQ4, and this IQ4 through the Virchow-Robin space fluid shifts from the Virchow-Robin space into the brain tissue. And so if there is going to be a localization, or if there's going to be an injury, then this CSF which is there accumulated in the Virchow-Robin space will get into the brain parenchyma and causes edema. So these are the experimental evidences are now supporting the lymphatic system and its a pathway in taking out the fluids and also some of the particles inside the space of fluid into the CSF and drainages. So in conclusion, then if you look at this, there are a lot of things are happening with the Virchow-Robin spaces. So what it goes with that? Now you look at this diagram here, and this is the Virchow-Robin space, and these are the vessels here, and this is the brain tissue here. So what happened is that if there is a subarachnoid space which is filled up in this region, like this, in subarachnoid hemorrhage, it blocks, and the CSF gets from here into the interstitial spaces, and this forms the edema. This edema is called the brain swelling. Now, if we wanted to reduce this, then we have to remove the subarachnoid hemorrhages and the fluid from here, so that the pressure gradient does not go from here to this side, but in turn, it reverts back and comes back like this. So in turn, it reduces the cerebral edema. So this is the concept of the CSF being let out from this space down. But how will you do that? That you do from the ventricular drain, or we have to go to the basal cisterns. When you go to the basal cisterns, then the clearance of the fluid is much better. So this forms the rationale for cystostomy. The cystostomy basal, the whole rationale is to let out the CSF which is accumulated at the basal cisterns, and also not only the basal cisterns and in the Virchow-Robin space. So the basal cystostomy is nothing but a CSF let out procedure. A simple way, CSF let out procedure. This is basically, if you look at it, was the old technique which was used for some other techniques, like there, Professor Yasser Gil going to talk about many things. You know, he is there next to me, and he was the one who advocated the cisternal openings for aneurysms. So it all started from his time. And the first time it was started by Ip Cherian in 2006, and later on it was followed by Roy Thomas Daniel, myself, and Yong Wang. And today, all over the world, many surgeons are doing this procedure. This procedure is considered as complex procedure, and it demands some surgical skill, and you need a good microsurgical training. And it is not possible in all cases, but in majority of the cases, it is feasible. Right, so this is very important point. Now you can see the basal cistern is here, and there is a Lilliquist membrane which divides the supratentorial and also the infratentorial CSF. Now, if we wanted to reduce the fluid, then we have to open the Lilliquist membrane so that the infratentorial compartment is also released from the CSF being locked up due to subarachnoid space. So that is the point here. Now you can see this is the diagram of the basal cisterns with the liquid membrane. You can see the liquid membrane here. Here is the third now, and go to this is very nice. Optic nerve, carotid artery. Between the optic nerve and the carotid artery, you can find the liquid. And once you get into the liquid, you are in the infratemporal compartment. That means you come through here and in this space. So this is very important. I will show you some of the pictures, like why it is important to do with the microsurgical procedure. Now, you know very well that microsurgery has taken up, and we are all here today because of microsurgery only. And when we do with the macrosurgical techniques, like, just do a decompression, get away from that, we will never reach the cisterns. So you need microsurgery to do cisternostomy. And when we remove the lesser wing of sphenoid, then you go very close and your surgical technique becomes much, much easier. Now, as you see this Taj Mahal into different ways, similarly the basal cisterns will look when we approach from one area to another area, that is from the subfrontal area, cisternal area, and through the lateral approach. So this is what I said about it. In this, all these things, the basal cistern will look different. The surgeons need to get familiarized with this technique. The pterional approach, here you can see the classical pterional approach, the frontal lobe, the temporal lobe, and here is the lesser wing of sphenoid here. I'll show you in the live case so that you can appreciate it better. We are all very familiar with the pterional approach. Here is a patient of a head injury patient. You can see that patient is positioned in a pterional approach. That is a curvilinear incision is made, and then you do a large craniotomy, and you can find the lesser wing of sphenoid here. You dissect the lesser wing of sphenoid, and also you can drill out the lesser wing of sphenoid as close to the anterior clinoid process as possible. This will give you a good approach to the basal cistern. Many times, a lot of surgeons ask how to go to the basal cistern. They keep asking us how do they go to the basal cistern? The basal cistern, if you want to go to the basal cistern, your craniotomy should be at the base. It starts from the base. Then only we can go to the basal cistern. So to do a basal cisternostomy, one should understand that your craniotomy should go to the temporal and the frontal base, and the lesser wing of sphenoid must be removed. Now, after the lesser wing of sphenoid is removed, you can see here, you can do with the patty, with the menial patty, this brain is slightly edematous. You can see the optic nerve with the cottonoids. You don't need much of a retractor, but still you can do it because you have removed the lesser wing of sphenoid, and you are very close to the anterior clinoid and the carotid artery, and also the optic nerve. Now here is, now divide between the optic nerve and the carotid artery. You can see the liquid membrane. Open the liquid membrane, and then you can always place one drain tube here. I hope that you can appreciate this. And this technique can be used here. You can see this is the pre-op position, and this is the post-op one. The technique was the same. The contusion is removed, and cisternostomy. Post-cisternostomy, you can find a good reduction in cerebral edema. Now, this is another case. You can see here, this is very severely injured brain here. Go to the base. Still, you can reach the optic nerve, between the optic nerve and the carotids. And you can see the chasm here. CSF must be let out slowly and slowly. And once you start letting out the CSF, you can see the brain becoming relaxed. When brain becomes relaxed, it is much easier. You can see here, and this place, this is lateral to the carotid. You can still go to the liquid membrane. You open it, then you can see the basilar artery. So why we wanted to do this is more of a microsurgical technique, and you need patience in while you do the trauma surgery. In trauma surgery, it's not a fast surgery. You don't need to be in a hurry to do the decompression. Just do the decompression, get away. But when you go to the base, you can always go very close to the basal cisterns, and the basal cisterns can be very nicely drained. Now, this is another example. You can see here the clots are removed, and then after the basal cystostomy, you can find a good decompression here, and the brain is much better than this is what the drainage tube is here. You can see the drain tube in this place in front of the ponds. Now, I'll show you some cases here. You can see here another craniotomy, large craniotomy. It looks like you can see you are doing an aneurysm surgery. This must be the position. Once you remove the subdural, extradural will fall down, and then you can always do the same technique. You can do the same technique. You can see here the optic nerve, the carotid. Between this, you can open the cisterns, and then you can always put a tube here. This video shows you should be very meticulous. Now it looks as if that you are not going to drain. It looks as if that the brain edema is very high. But once you go to the basis and start releasing the CSF, when CSF is let out, you can find very good anatomy. So you have to be very, very meticulous in your surgical technique. So finally, the microsurgery comes to this place. So my full point here is about microsurgery in head injury patients. Now I will show you one of the videos here. Now this is a live video, slightly faster. You can see this is a frontal lobe, it's a temporal lobe here. Lesser being is removed, and this is the optic nerve. We keep putting the saline. A CSF keep on coming, and you can find there is edematous here. It is edematous, but you can retract with your suction itself. You can retract with your suction. It is, you have to take patience. Little bit of patience is important. And then you can see the posterior cranial process there. This is lateral to the optic nerve here. Yeah, this is the A1 there. And keep washing, keep on washing, keep washing, wash, and take out the subarachnoid blood as much as possible. This subarachnoid blood is the one which obstructs the CSF pathway. So once it is cleared, the CSF is released. It is released where it was occupied in the cisterns and also in the Virchow-Robin space. So it becomes lax and lax, and you find the edema is coming down. So you will get a very nice relaxed brain at the end of the procedure. Now you can watch here. This is the live surgery. This is the live surgery, and there's no editing here. This is the live surgery. There is no editing here. So you can appreciate how the surgery should be done. So in the post-op, you can see that this brain is lax here. You can look at this brain is lax. So this point is very important, that we have to achieve to this amount of decompression, this amount of internal decompression. I put this word as internal decompression. The external decompression is the decompressive craniectomy, which we are doing for more than 100 years. But now this is the internal decompression. When you take out the CSF from here, the brain gets lax. You can always put back your bone flap. This is another technique. This is another technique. And so now you can see here again, this is the optic nerve. As CSF start coming out, you can see that. CSF start coming out. Gently open the arachnoids here. Open the arachnoid, optic nerve. So it is a microsurgical technique. Basically must have a lot of patience when you do trauma surgery. So you see the liliquist here. You open the liliquist. Yes, there you are. When you open the liliquist, you certainly will find more CSF coming from the infratentorial compartment. So you open the infratentorial compartment also nicely. You can see that now the rent is made, infratentorial compartment, and then wash. The more you wash, it is better. and then you put one drain here in this place and bring it out. So this is an important procedure. And we know that the fourth brain trauma foundation, the CS of laid out with EVD has been accepted as one of the laid out procedure. And in near future, basal cystinostomy will also be accepted as one of the procedure for neurotrauma patients. Now you can see that very nicely. Now this is the pre-op and post-op situations. You can see the scans. And if you wanted to see a better video, you can go through this video. This is with the subfrontal approach. This is a very edited video. After removing the frontal contusion, you retract. It's optic nerve. Ease out the arachnoids gently. And gently tease out. And nicely tease out here. That's a stalk. Pituitary stalk there. Optic nerve, optic chiasm here. Lateral to the optic nerve. Carotids here. You can see this, the carotid, optic nerve, and here is the Lilliquist membrane. You can use any instrument of your liking for a shot. That's the vertical. You can see the basilar there. Yeah, and wash. Give a good wash. The most important is giving a good wash. I like to dissect very widely when I get more opportunity widely and remove the subarachnoid to the maximum. Maximum subarachnoid hemorrhage should be removed in head injury patients and trauma. That is very, very important for CSF bleeding out in head injury patients. Yeah, this is the pre-op. You can see after the decompression, just a craniectomy here, the brain bulges out. This is after cystinostomy. It is lax. Then you can put back your bone. I understand this is another case, pre-op. This is post-op, relaxed brain. In what of the time, I like to cut short my talk. This is the CS of now. We'll keep it down for some time, then later on elevate it to the head level and follow it up regularly. This is also, you can also do it with a small craniectomy. You don't need a large craniotomy. And then you can do a small craniectomy and still can do basal cystinostomy. These are the pre-op and post-op series of scans. And I can show you. After you do a cystinostomy, you can find the brain is so lax here. It's a small craniotomy, not large, not a large one. Yeah. So these are the ICP monitors you can use before cystinostomy, after cystinostomy. ICP is very much reduced. The same thing can be done in pediatric patients, which is very tough, but still it is possible in pediatric neurosurgery in trauma. Now, as I said that it is not possible in all cases, there are few cases in spite of cystinostomy, you have very bad meridian edema, one cannot do anything. But I also like everyone to go through the literature. We have done published quite a bit of articles on this. These are the literatures that need to be studied to understand the basal cystostomy. And of late, this is the latest one which has come on October 23, that potentiating lymphatic drainage minimizes post-traumatic cerebral edema. So I recommend all these articles to be read by all neurosurgeons all over the world. Now I have to thank my friends, Aib Cherian and Wang, for coordinating with all my work. And I thank you very much for giving me this opportunity. Thank you very much, Dr. Ahmed and my dear friends.
Thank you very much, Professor. It's a great lecture and great results. Okay. Anyone have any question? Okay. Thank you, Professor. Do you hear me, Professor?
Thank you.
Thank you very much. Now we'll have a word from the Prime Minister. Okay. Here Harry will present him.
شكرا جزيلا. رغم انشغالاته الكبيرة يحرص الأستاذ الدكتور عبد العزيز صالح بن حبتور رئيس مجلس الوزراء إلى أن يكون علامة فارقة وبصمة وضوءا لا يخبو في مثل هذه الفعاليات الوطنية. والآن سوف نكون مع كلمة دولة رئيس الوزراء الأستاذ الدكتور عبد العزيز صالح بن حبتور. تحية لهذه الهمة الوطنية العاقلة.
بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على الصادق الأمين محمد صلى الله عليه وعلى آله وصحبه وسلم. شكرا جزيلا للأساتذة الأعزاء، جمعية جراحين المخ والأعصاب التي نظمت هذه الفعالية العلمية الاستثنائية بالاشتراك مع عدد من المؤسسات في اليمن، وهي جامعة 21 سبتمبر وأيضا المجلس الطبي الأعلى. وبطبيعة الحال الحقيقة نحن كلمتنا لن تكون في أهمية تلك المحاضرات التي استمعنا إليها وقدمت من قبل الاختصاصيين في هذا المجال. أنا وصديقي العزيز محمود الجنيد جئنا للمشاركة المعنوية معكم، لكن ندرك أهمية هذا المؤتمر وساعاته ودقائقه، ولكننا قلنا بالضرورة أن نسهم معكم في المشاركة باعتباركم الحقيقة الأعلى اختصاص في الوطن، كل الوطن، وتقدمون أعظم الأعمال العلمية والتطبيقية للمواطن اليمني الذي حرم كثيرا من هذه الخدمات. أنتم الحقيقة يصعب الحديث حول إنجازاتكم العلمية لعظمتها، لكبرها، لهذا التطور النوعي الذي وصلتم إليه من خلال تلك المحاضرات والعمليات النوعية التي قمتم بها وتقومون بها، وبعضكم لا زال طالب في هذا المسار وهذا المجال، وسيصل بإذن الله إلى ما وصل إليه الاختصاصيين في اختصاصكم الدقيق. الدكتور كان يحدثني مجاهد ما صار حول بعض العمليات الدقيقة، وهي فعلا دقيقة، وكانت واحدة منها يوم أمس